Okay. Hello, everyone, and welcome to the joint educational webinar hosted by the American Academy of Sleep Medicine, International Assembly, and the African Sleep Network. We are delighted to be featuring a fascinating presentation of sleep, infections, and practice. The expert speakers will reveal how infections disrupt sleep and impact patient care. We will gain practical strategies for the diagnosis and management of human African trypanosomiasis, HAT, in Nigeria, and learn how to build sleep lab services in resource-limited areas. By way of introduction, I am Maya Ramagopal. I'm a pediatric pulmonologist, and I'm the medical director at the Robert Wood Johnson Sleep Lab in New Jersey in the US. And I'm also the AASM International Assembly Ambassador from North America. The AASM International Assembly brings together sleep doctors and allied health professionals from across the globe, with our sleep ambassadors spanning the globe from across Europe, Asia, Africa, Oceania, and the Americas. The mission of this assembly is to provide a platform for sleep medicine professionals to connect, exchange ideas, and learn from each other. Before we introduce our speakers, I would like to remind you that your audio and video is off. We encourage you to include any questions you may have for the speakers in the Q&A of the Zoom platform. The questions will be answered at the end of this presentation. And as a reminder, this webinar is recorded, and if you are unable to stay through the whole thing, you can always catch up later. Dr. Farag will introduce the speakers.
I am Sameh Farag, Director of EG-Pro Pharma and American Academy of Sleep Medicine International Assembly Ambassador. I am based in Kenya in Africa. Now, allow me to introduce our speaker today. We have Professor Abubakar Garabti, is a consultant of infectious diseases and Professor of Internal Medicine at the University of Maiduguri, currently serving as Director of Research, Innovation and Development at Federal University of Health Science, Azhar. With over 30 years of medical experience, he has led clinical, academic, and research innovation, published extensively, and contributed to national and international health programs, including Nigeria's Infectious Diseases Committee and the U.S. PEPFAR program. Also, we have Daniel Herold, is a prominent figure in sleep medicine and technologist, having served as pioneer at Mayo Clinic in Rochester, Minnesota, USA for over 43 years. He has significantly advanced technology, training, and care in field of sleep medicine. He holds a position of Assistant Professor of Medicine at Mayo Foundation for Medical Education and Research, where he supervises the sleep laboratory. Harold's extensive experience includes rules in practice management and hardware diagnostics. Also, we have Dr. Karin Schubameyer. He is Associate Professor in Physiology at University of Witwatersrand, Johannesburg. Trained in clinical hematology in Paris and postdoctoral research in sleep and circadian rhythm at Harvard's Medical School. Her work explores the links between sleep, circadian biology, and non-communicable disease, especially in HIV and long COVID contexts. She is chair of a science committee of the South African Society for Sleep and Health, and member of the World Sleep Society. Thank you for joining us, Professor Schoemeyer.
Apologies. Okay, so I just wanted to say that I will talk about sleep and immunity and about human African trypanosomiasis, the sleeping sickness. And I will not go into the management, which will be dealt with way more competently by Prof. Gabati just after this. Okay, so indeed, we know that during infection, we display something which is something that we call sickness behavior. This sickness behavior, of course, there's the fever, and then we have decreased movement related to that. And then we tend to sleep more, even though this sleep can be a disruptive type of sleep where we wake up, it's agitated, it's fragmented. And so this is typically what we see in humans. We curl up in bed, we are under our covers, and we are shaking and having chills. And the mice have pretty much the same type of behavior. It's a very common mammalian behavior. Very simply, this is, a few things we know about how sleep is affected by immune activation. And it's way more complex than what I'm going to talk about, but just to give a bit of background for the sleeping sickness in particular. So when we have an infection, we start, our macrophages detect the infection. They recognize these general patterns that this is not part of the self. And then they start becoming activated and secreting cytokines like tumor necrosis factor alpha, interleukin-1, interleukin-6, etc. So the thing that's interesting is that those cytokines are also somnogenic. So that explains a little bit why every time we're infected, we're fighting an infection, we tend to try and fall asleep. So clearly that is beneficial, to fight the infection. We're basically gearing all our energy towards fighting the infection. And the result of this is that we may have an increase in slow wave sleep in our acute response to infections. However, and same thing, if we treat people with interferon gamma, which is produced by our natural killer cells, we have this tiredness and lethargy. So we use interferon gamma a lot in hepatitis C treatment, and this was the main side effect. So clearly, we know that cytokines are going to trigger sleep behaviors. What we know is, though, in terms of chronic type of immune activation or inflammation, this sort of sickness behavior, now it's mainly we see that people start having fragmented sleep, so disrupted sleep. And this is something that's, as you'll see, is a bit common to what is happening in sleeping sickness. All right, so I'm just going to show very quickly where it's distributed. I mean, myself in South Africa, there's no sleeping sickness, but obviously we do have travelers who may come to the hospitals and get treated for that. And that's something that we don't necessarily, I think, as doctors here, keep in mind. And that's why it's so important to review a little bit these concepts. Okay, so again, a bit quickly, this is the cycle of the trypanosome from the tsetse to the mammal. So first we have a tsetse fly that got a blood meal from an infected human. It starts with that. Then we have these forms which form inside the gut, which become these cyclic forms. And those are going to go to the saliva glands of the tsetse fly, become these metacyclic forms. And at some point, we're going to have another blood meal to a non-infected human or mammal. Again, it can be a cow as well, in the metacyclic form. And then we have these new forms called the slender form or the stumpy form, which are going to coexist in the human. And that's when we start having the first signs of the infection. And eventually, those forms can get into the brain and to adipose tissue as well. So that's a very, very quick summary of that cycle. But you see there is a part where basically we have a differentiation into the blood, which is going to be that prodromal phase, and then something that's going to lead to the central nervous system type of manifestation. The course of the disease is this hemolymphatic stage first, this stage 1, and 1 to 3 weeks after the bite. So we have an intermittent fever that's going to appear, some lymph node swelling, some splenomegaly, which is the normal reaction to a hematogenous type of infection. Skin rashes can appear, and headaches. And then now we get to the meningoencephalitic stage, which is stage 2, which is when the trypanosome crosses the blood-brain barrier. And then we start having symptoms, neurologic symptoms, psychiatric manifestations, and those sleep disturbances. Okay, so the first question is how do the trypanosomes get into the brain? The story is not 100% clear. It looks like it might be a combination of factors. We know that there's no disruption of the blood-brain barrier, but they can still maybe cross it. So you can have crossing without disruption. There could be also a passage through the blood-cerebrospinal fluid barrier, and that's very likely because we know that there are lots of parasites in the choroid plexus, which is where the CSF is formed from the blood. And then by simple diapedesis, a little bit like the lymphocytes. So that's how they get into the brain. So the choroid plexus is quite key to that, apparently. And then also we know that some of the cytokine signaling are going to also help the trypanosome pass into the brain tissues. So the thing also is that the trypanosomes cannot stay very long in the cerebrospinal fluid because they don't survive very well there. And so they have to very quickly get into these niche tissues like the brain. And once inside the brain, the trypanosome starts concentrating in 2 areas, but I'm going to focus on the hypothalamic areas. And before I go into more details about the infection itself, I'm going to just remind you quickly about what we find in this area. So not only the hypothalamus, but also just nearby in the brainstem in the reticular arousal system. Okay, so this is a human brain, very schematic again. And let me just grab my laser pointer so that you can see. So here we have what we call the monoaminergic nuclei in green, which are very important in wakefulness and are very slightly active during non-REM sleep. And then we have here in blue, we have the cholinergic nuclei. And these cholinergic nuclei are also somewhat active during awake, but they're mainly active during REM sleep. Then we have the ventrolateral preoptic area, which is our main sleep center, which sends basically GABA and galanin, so this inhibitory type of neurotransmitters, and will tone down cortical activity, leading to sleep, and tone down, of course, our monoaminergic nuclei, preferably. Okay, so these are our different monoaminergic and cholinergic nuclei and the sleep nucleus. Another thing that's important in this whole system is the orexin nuclei, and you probably all know them from narcolepsy. And we know that the orexin nuclei nucleus is really spreading everywhere. So it's a very interesting type of neurons which spread not only to the wake nuclei themselves, maintaining wakefulness. So we know that the activity of our orexin nucleus is really to maintain our wakefulness during the day. It helps also, for example, in mice when they're very hungry, the orexin nucleus seems to be very active to maintain their wakefulness so that they can keep their foraging activity. So orexin nuclei are important to maintain wake, very important. We know that during narcolepsy, which is an autoimmune disorder, we basically have a decrease in our orexin neurons and the orexin neurotransmitter itself. And the manifestation of narcolepsy, if you remember, is that people are extremely sleepy during the day. They might fall asleep spontaneously, and their sleep starts with rapid eye movement during the day, which is very unusual. So this is what we call the SOREM, the sleep onset rapid eye movement. And remember, as soon as our orexin is no longer working, these guys, the three monoaminergic nuclei, are no longer able to give a wakefulness signal. The LDT can still be very active, so the cholinergic nuclei can be active, and these are important in REM. As soon as these are no longer active, the sleep nuclei are going to be active, and so sleep nucleus, which is active, so the Velpo being active, and plus the cholinergic, that makes us have REM. All right, so just a little reminder of all of this, and you'll see it's very very similar to what we actually find in sleeping sickness. So all these symptoms: sleep onset, rapid eye movement, daytime sleepiness, and sleep fragmentation. All right, and the final thing, that we always look at is the SCN, our master clock, which is also in the hypothalamus. So that's suprachiasmatic nucleus, which receives input from the retina directly through the retinal hypothalamic tract, and basically enables us to train to the sleep to the Earth light dark cycle. Okay, and the circadian clock basically gives higher and higher firing during the day, keeping us awake and talking to the orexin nuclei, and then during our normal night, it tones down its firing and lets us fall asleep. All right, so how does this correlate with what we understand about the sleeping sickness mechanisms? Again, remember that I told you that we find the trypanosomes a lot in the choroid plexus, and then they go to the hypothalamus. And around the hypothalamus, so we have the SCN and we have our orexin nuclei. So this is where all our trypanosomes seem to be clustering. And so what seems to be happening is that so if you look here, this is a typical sleeping sickness patient, and this was in this very nice study by Buget et al. So that's Buget et al. Who showed these patterns. So this was recorded in Angola. And so this was a patient who had really the phase 2, quite severe phase 2, and very low orexin, by the way, in their CSF. And as you can see, they went from, during the day, they were still cycling between non-REM, REM, a lot of REM. And so from wake to REM, from wake to REM. And then during the night where they're supposed to be sleeping, so they are sleeping, but with a lot of interruptions during that time. So it's very fragmented sleep. And then as soon as they're treated, you see that all this sleep that happened, all the sleep that we were getting here during the daytime now is no longer happening. And now we are having a much more consolidated sleep during the night. If you look at activity, so this is recorded using a sort of ActiWatchers, a little bit like this one. So it's just recording at the level of the wrist. And you can see that it's very hard to see a normal rhythm here. I mean, normally we're supposed to be seeing activity during that time, and absences of activity if you see that blue line, we shouldn't be seeing activity at this time. And you see in the sleeping sickness patient, we see lots of activity. Basically, we are no longer having a normal built-up sleep-wake rhythm. And so the patient, after the treatment, you see, now has reestablished at this point that they have much better sleep. So they have much less activity here during the nighttime and normal activity during the daytime. So, I started giving you a little bit of information. It looked a little bit that like these trypanosomes were getting, near the hypothalamus, near these very important orexin nuclei. And because of that, of these sleep onset rapid eye movement that we see in sleeping sickness, because we're seeing also this daytime sleepiness and the sleep fragmentation. It looked so much like a phenotype of narcolepsy that someone at some point decided, well, why don't we measure orexin and see if the orexin levels are decreased in sleeping sickness. And in the study by De Villiers and et al. From 2008, you can see, so this is, if you look at typical people who have narcolepsy, you see that their orexin levels are so it's called also hypocretin orexin, so it's the same term, are very low in this person. And as you can see here, when you're in stage 1, they're sort of normal. Intermediate stage also sort of normal, so intermediate stage is between the two, basically. And when you get to stage 2, this is really that meningoencephalitic phase, it's much lower. And so basically looking very much like a profile of narcolepsy, although probably not as low as in narcoleptic patients. Again, it's an N of 4, it's not that much. So then if you look at animal models of sleeping sickness, so this is where they injected trypanosomes in rodents. And what they found is that, so this is your healthy mice, and this is the orexin neurons, and you have a very tight and quite vivid network of orexin neurons, but you have a very small network in those who are sick with with sleeping sickness. And same thing. So here, this is also the same thing that they're trying to show, that basically you have way less connections, so less nuclei and also less connections. So there's clearly some kind of something happening with with these neurons. And the thing that's happening is that here, if you're looking at the number of cells, they clearly decrease over time in those animals. And if you look at the number of dendrites of these orexin cells, they decreased significantly once they've been infected. So there's clearly some evidence that the trypanosome is affecting orexin neurons. Okay, so the other parts that we were thinking, remember we were talking about how in general we have sickness behavior. And so this is, what we're seeing also probably in sleeping sickness, which is this neuroinflammation. So in response to the penetration of these trypanosomes in the brain, you have a massive infiltration of inflammatory cells, which then recruit the astrocytes and microglial cells. And microglial cells are basically the macrophages of the brain. And this will lead to TNF-R1 secretion, which is going to disrupt sleep. Because we think that there's definitely a direct neuroinflammation aspect that's present in sleeping sickness. And finally, something of keen interest to me is the neuroinflammation, which is in the circadian clock, so in the suprachiasmatic nucleus. So very interestingly, so in this study by Lundqvist et al., they again injected the trypanosome. So again, these are rodents, and they were looking at this as soon as they terminated the rodents. They were able to cut a few slices and look literally at electrical activity in rats who were healthy versus those who were infected. So 30 days after infection. And what they found is that basically there was no change in the SCN substructure. So there were no disappearance of cells like we saw for the orexin neurons, but they found a difference in the neuronal firing. So they saw that there was much more slower activity of the SCN compared to a control. This is what you're seeing here in the excitatory impulses. If you look at the frequency in the controls is much higher. That means it goes much quicker. Whereas in those who are infected with the trypanosome, the frequency is much lower. And they did the same experiment now, but this time just to look at these slices of SCN with cytokines. So this is now healthy rats, just healthy slides, but they inject cytokines into the culture, and what they see is basically a very similar aspect. So basically, their conclusion was that, well, yeah, the trypanosome may affect the SCN, but it's not directly through the trypanosome itself, whereas for orexin, we don't know exactly how it's affecting orexin neurons. It's not affecting the neurons themselves, but it's affecting their excitability, making them less excitable. And then SCN that's not, again, if it's not firing during wake, then it's just not maintaining the wakefulness also at the level of the orexin neurons. And it's preventing, so basically we cannot have a maintenance of wake, and that's why, that's one of the explanations, at least, that we think that's how sleeping sickness works. Okay, so in conclusion, we have, basically this parasite, the trypanosome, which affects SCN function through neuroinflammation, and also the orexin neuron structure, and which decreases directly orexin. But very interestingly, those effects are reversible with timely treatment. That's very important, and that neuroinflammation does not lead to neurodegeneration. So it's again, I think you'll hear much more about the management, but it remains a disease which can be deadly, especially when it reaches that phase 2. It does require aggressive management, and also knowing people. People should know how to detect it. And again, there are few studies, a few evidence that this is how the trypanosome, basically interferes with our sleep-wake cycle. However, I really think that there are more studies to be done.
So thank you so much, Dr. Schurmeyer. That was a fascinating talk. So next up, Professor Garbati will be joining us.
From the Federal University of Health Sciences, Azure in Nigeria. And I would like to thank the organizers for inviting me to make this presentation. I would like to make this presentation according to these learning objectives. Human African Trypanosomiasis, also known as sleeping sickness, is a vector-borne parasitic disease that is caused by protozoans of the genus Trypanosoma that are transmitted to humans by bites of tsetse flies, known as Glossina, which have acquired the parasites from infected animals or humans. Heart remains a neglected tropical disease endemic in about 36 sub-Saharan African countries. The WHO in 2023 reported that the current burden of the disease stands at less than 1,000 reported cases annually. But this is thought to be gross underreported, especially from remote areas. Rural populations that depend on agriculture, fishing, animal husbandry, or hunting are the most affected. In Nigeria, WHO records indicate that heart was last reported in 2012, except for the one case report that was diagnosed in a Nigerian in the UK in 2016. This has resulted in the neglect of the country in heart surveillance and control programs, since it is believed that the country is on course to eliminate the disease. However, Cameroon, a neighboring country to Nigeria, which shares borders with the Nigerian heart foci, continues to report cases. Interestingly, there has been reports of finding the human infective trypanosomes in animals in Nigeria, especially in companion animals such as dogs. This raises questions about the existence and true prevalence of heart in Nigeria, especially with regards to the source of infection and transmission route for the animal carriers. A recent systematic review that synthesized published reports on the prevalence of human and animal African trypanosomiasis in Nigeria, the trypanosome species involved, the spread of animal reservoirs, and the variability in diagnostic methodologies employed from 1993 to 2021. 3 studies that reported on 1,974 individuals who underwent testing for the disease were analyzed. Amongst them, 65 individuals were seropositive for the disease in 2 of the studies using the cat agglutination test for trypanosomiasis kit. Trypanosomes were detected from the blood of 23 seropositive individuals by various methods, such as microscopic examination of blood films or Buffy-Cut, and in vivo inoculation into mice or rats. One study also examined the CSF and detected parasites in the CSF of 4 patients. The third study did not detect any positive case within the sampled populations. The seroprevalence reported by these studies for various study sites across the country ranged from 0% to 9.6%, with a calculated average of 3.3%. The actual prevalence of heart as confirmed by parasite detection was as high as 4.8% in one study site, with a calculated average of 1.2% across all studies. Trypanosoma brucei gambians type 1 was reported as the causative parasite species, as detected by the Gambian-specific PCR. A recent study by Emmanuel et al. In 2025 that surveyed 72 asymptomatic people for evidence of TB Gambians infection in Oyo State, southwest Nigeria, reported a TB Gambians infection prevalence rate of 40.28% amongst the participants. This comprises of 55.17% men and 48.83% women, with persons aged between 51 and 60 years having the highest prevalence rate of 77.78%. Surprisingly, all of these participants are completely asymptomatic for either stage 1 or stage 2 heart-related signs and symptoms. The heart prevalence rate from this study is alarming compared to the 0.6% detected in Boko, Nigeria in 2016 and 9.3% detected in Abraka, Nigeria in 2010. A recent review has indicated a calculated mean prevalence rate of 27.3% for animal African trypanosomiasis, which is higher than the 16.1% in previous review. This indicates increasing AAT burden. A notable finding from this study is the presence of human infective T. brucei gambians in pigs, dogs, and cattle in Nigeria. Similar findings have been documented in various sub-Saharan African countries. This raises additional concerns regarding the potential role of animals in the epidemiology of heart and the possibility of heart reemergence with new epidemic clones of the parasite. Although the precise role of these animal hosts or carriers in the Gambian's form of the disease is not entirely clear, their presence poses a potential threat to the goal of eliminating heart transmission to humans by 2030. While the zoonotic potential of T. brucei gambians has been a subject of significant discussion over the years, the confirmation of its presence in animal hosts highlights the possibility of transmission between humans and animals that should not be neglected. How does the immune system affect sleep? The connection between sleep and the immune system revolves around the complex interplay between the immune system and the sleep-wake cycle. Certain cytokines such as interleukin-1, interferon gamma, and tumor necrosis factor alpha are pro-inflammatory and are key players in fighting infections. They are also potent sleep-promoting substances. During an infection, their levels rise, forcing the body to rest and recover, a process called sickness behavior. Following an infection, the immune system mounts a response, releasing those pro-inflammatory cytokines. While this promotes sleep, the symptoms they cause severely disrupt sleep architecture. Therefore, the sleep disturbance in trypanosomiasis are not just feeling tired. They are a profound dysregulation of the sleep-wake cycle, characterized by disruption of the circadian rhythm, where the normal 24-hour sleep-wake pattern is completely lost. Secondly, it causes sleep inversion, when the patient sleep more during the day and are awake at night. It also causes fragmentation of sleep, where sleep is broken into short, erratic episodes throughout the 24-hour period instead of one consolidated nighttime block. And also, sleep onset REM periods, so-called SOREMs, are also a key part of this disruption. And this is a key diagnostic feature when patients enter the rapid eye movement sleep almost immediately after falling asleep, which is abnormal. We know that normally the REM sleep occurs after about 30 minutes of non-REM sleep. The mechanisms through which the parasite causes sleep disturbance is multifaceted and not yet fully understood, but it involves a cascade of events from infection to severe neurological disruption. The initial event is the infection and invasion of the central nervous system. Following infection by the Trypanosoma brucei, it multiplies in the blood and lymphatic system, causing the first stage, the hemolymphatic stage, which features symptoms like fever, headaches, and joint pain. Then it crosses the blood-brain barrier, which is a critical event that leads to the neurological symptoms, including sleep disturbances. This mechanism is still being studied, but involves the parasite triggering widespread inflammation, which can make the blood-brain barrier leaky. It may also actively interact with and penetrate the barrier cells. Once inside the central nervous system, the parasite causes neuroinflammation and brain dysfunction. Once in the central nervous system, the parasite does not massively infect neurons. Instead, it triggers a devastating immune and inflammatory response that is responsible for the damage. The presence of the parasite in the brain triggers macroglia and astrocytes to release inflammatory cytokines, particularly tumor necrosis factor alpha, interleukin-1, and interferon gamma. The neuroinflammation specifically affects key areas of the brain that regulate sleep and the circadian rhythm, such as the suprachiasmatic nucleus, which is involved, which is called the master clock of the brain. This disrupts the circadian rhythm, leading to the loss of the normal sleep-wake cycle. Then the hypothalamus, which is involved in sleep regulation and hormone release. Its dysfunction contributes to sleep fragmentation and inversion. While the pineal gland, which is responsible for producing melatonin, and the hormone that promotes sleep, its function is disturbed, further damaging the circadian rhythm. The fourth mechanism through which human African trypanosomiasis can cause sleep disturbances is dysregulation of the sleep-promoting system. A specific area in the front of the hypothalamus, the ventrolateral preoptic nucleus, is crucial for initiating sleep. It is thought that the inflammatory response may alter the function of this nucleus and its interaction with other brain regions, like the wake-promoting tuberomammillary nucleus. The imbalance between these systems leads to the inability to maintain a stable state sleep or wakefulness, resulting in the characteristic fragmented sleep patterns. The fifth and final mechanism is alteration of neurotransmitters. The inflammation and brain damage can also disrupt the normal balance of neurotransmitters involved in sleep, such as histamine, which is involved in wakefulness, noradrenaline, and serotonin. The diagnosis of human African trypanosomiasis has seen significant advances in recent years, moving towards simpler, faster, and more specific tests that can be used in remote rural settings. The latest diagnostic steps follow an algorithmic process that flows through 3 key phases designed to first screen large at-risk populations, then confirm the infection, and finally stage the disease as to whether it is in the hemolymphatic stage or the meningoencephalitis stage to determine the appropriate treatment. With the screening test, the goal is to quickly identify individuals who need further testing. Primary tools are rapid diagnostic tests using finger prick blood samples that provide a result in 10 to 20 minutes. They have largely replaced the older, more complex cat agglutination test for trypanosomiasis for initial screening in many areas. The test detects antibodies against specific antigens of Trypanosoma brucei gambians, which causes over 95% of cases. The advantage of this test is that it does not require electricity, cold chain, or specialized training, making them ideal for field use. If the test is positive, the patient proceeds to the confirmation phase. If the test is negative, human African trypanosomiasis is effectively ruled out, and no further action is needed unless clinical suspicion remains very high. The screening test must be followed by diagnostic confirmation. A positive screening test, like you said in the previous slide, is not enough to start treatment. It utilizes either the SD byline heart or the heart surrogate set with sensitivity reaching up to 90 to 98% and specificity between 97 and 99.5%. So the presence of the parasite must be confirmed, as we said, visually or by molecular methods to confirm the diagnosis, and this is the prerequisite for treatment. The first diagnostic method is the mini anion exchange centrifugation technique, which is now considered as the gold standard for confirmation. Specificity is about 80%, but it is about 100% specific. If the patient has enlarged lymph nodes, fluid can be aspirated from the lymph nodes and examined directly under a microscope for motile trypanosomes. The second confirmatory test is the capillary tube centrifugation, which is used to examine the buffy coat of parasites. It is less sensitive, but specificity reaches up to 100%. And there's the molecular method, which is the PCR, which is more than 95% sensitive, about 100% specific, but it's typically used in reference laboratories for confirmation, especially if one has an ambiguous case or for surveillance. The fourth test is the loop-mediated autosomal amplification, which has sensitivities as good as the PCR, about 95%, and then it's highly specific, up to 100%. The third phase prior to commencement of treatment is staging, which is considered to be the most critical step as a treatment for the late stage. That's when the parasite has crossed the blood-brain barrier, is more toxic and complex than for the earlier stages. A lumbar puncture is performed on all confirmed cases for analysis of the cerebrospinal fluid. When the white cell count is less than or equal to 5 cells per microliter is considered an early infection. That's a hemolymphatic stage. Here, the central nervous system is not considered to be involved. But in late stages, the meningoencephalitic stage is said to be present if the white cell count is more than 5 cells per microliter. This indicates central nervous system invasion and requires late-stage therapy. Finding trypanosomes in the CSF automatically classifies the patient as late stage, regardless of the white cell count in the CSF. Fexdenidazole, the first oral treatment for both stages of Gambian's heart, was approved by the World Health Organization and the European Medicines Agency. WHO has also approved fexdenidazole for the treatment of the rhodesians form of the disease in those aged 6 years and older and weighing more than 20 kilograms. Acozabirol is currently in advanced clinical trials. It is a single-dose oral treatment that appears to be effective for both stages of Gambian's heart. It also appears to be effective against both stages of the rhodesians form of the disease. Acozabirol, if widely approved, could be a key tool for achieving the 2030 elimination goal, as treatment could be administered immediately after a confirmed diagnosis, even in the most remote settings. Nifurtimox eflornithine combination therapy remains a vital backup treatment, especially if fexdenidazole is not suitable in children less than 6 years or those that weigh less than 20 kilograms, or if there is treatment failure. However, this medication requires IV administration. Children younger than 6 years of age of body weight of less than 20 kilograms will continue to require treatment with suramin or melarsoprol, as fexdenidazole has not been studied in clinical trials in this patient group. In conclusion, the fight against heart is a major public health success story. The combination of new diagnostic tools and revolutionary oral treatments has brought the goal of elimination within reach. The current challenge is to find and treat the last remaining cases in every remote and often unstable regions of sub-Saharan Africa. One of the prerequisites for a disease to be eradicable is the absence of animal reservoirs. Therefore, in addition to undetected human infections and inadequate diagnostic tools or diagnostic capacity, the presence of potential animal reservoir hosts is a major challenge to the complete elimination of heart in Nigeria and across sub-Saharan Africa. Without that, thank you once again for inviting me to make this presentation, as I look forward to your questions and comments. Thank you.
Thank you very much, Professor Garbati. Now joining us is going to be Daniel Harold.
My name is Dan Harold, and I am assistant professor of medicine at Mayo Clinic in Rochester, and been doing sleep medicine for a long time, and doing sleep technology for a long time as well. Thank you. And I'm going to switch gears here a little bit, starting from scratch. Sleep laboratory development and essentials for preparing to do sleep studies with a resource-limited environment. And that's what I was asked to talk about today. And so I'm going to be giving some basic essentials that that sleep laboratories require as minimums to be able to do sleep studies, and some options for equipment, and a little bit of knowledge on how to do staffing and things like that. The first thing that you really need is to have a provider, a sleep medicine or a doctor that is preferably trained in sleep medicine, but not necessarily has to be. I'm not sure of the rules in Africa. We have some physicians that practice there. I was asking them and trying to figure out exactly what the situations were. But if you don't have a sleep medicine trained provider, if you're going to be starting from scratch, a pulmonary, cardiovascular, neurologist, psychiatrist, family medicine et cetera, are there. And there's a good way when you're starting a sleep laboratory is using the American Academy of Sleep Medicine, or the AASM, which is the AASM international discussion here, and being able to use the resources that they have there. They have a large number of resources, including physician and staff training. So typically, like what we would have here in a very well-developed sleep center are pulmonary critical care, neurology, psychiatry, ENT, pediatrics, nursing, and then people that would actually do medical assistant or administrative assistants type of roles there. You can kind of see in the core roles and responsibilities here who generally takes care of what, but in general, it's been my experience and practice that all physicians, not depending upon specialty, do a very good job in learning and managing care in patients that have sleep medicine. Obviously, the biggest sleep disorder that most sleep laboratories deal with is obstructive sleep apnea, right? And so the basic sleep laboratory will be able to define what sleep apnea is and how to treat it. Another key element is staffing of technologists. And that's where I come in. That's where I was trained. That's 40 years ago, on pen and paper and doing old school type sleep studies. But technologists are referred to as polysomnographic technologists, or PSG techs, sleep techs, whatever the terminology you want to give to them. But the polysomnographic technologist is probably one of the most critical roles after getting having a provider or a nurse practitioner or physician's assistant that is actually managing these patients. If you're able to find what is called a registered polysomnographic technologist like myself, an RPSGT, the RPSGT is an international certification. The test is given in English only currently, but we've tested worldwide. And but if you're unable to have the luxury of a registered technologist, there's a lot of training that you can actually get. There is the AASM A-Step program, and those are given at training technologists in medical institutions. Those that don't have training in sleep can get that on an online course and didactic instruction within the A-Step curriculum. There are the American Academy of Sleep Technologists, or the AAST, which has a lot of training resources that are out there as well. There are small schools that one can attend, week-long, month-long type training facilities that you can go to and do that. And then there's outside consultants that can actually come in, set up, train. And on the outside part of that, there are a number of companies that actually go out and you can hire sleep technologists or sleep services to do all of that for you. So there are a number of different ways that you can manage this, but my understanding is from a limited resource is to set up a sleep laboratory. That was the desire. And so that we've found that trained EEG, electroencephalographic technologists, or respiratory therapists are good candidates for those that are untrained in sleep medicine, but deal a lot with the brain waves and the respiratory type of activity that goes into there. The overview is, you can read this slide for yourself, but generally there's a number of things that the Center for Sleep Medicine polysomnographic technologists do. And we work collaboratively with nurses, physicians, NPPAs and other allied health staff to be able to see patients with sleep medicine, sleep disorders, and those kind of things. Our laboratory, the laboratory that I have set up here, is a pulmonary laboratory, but it has a large portion of neurologic disorders that we actually take care of. So we do full brainwave activity monitoring, pediatric full activity brainwave monitoring, and those kind of things. But I have been partnered with and used as a resource to set up laboratories in the United States and Europe that are based with Mayo Clinic, where I work, and set up those laboratories in other countries as well, using networks of people that we know of to be able to set those up. So we have a variety of differing types of sleep medicine laboratories, but specifically most of them are for the diagnosis of obstructive sleep apnea. So what does the polysomnographic technologist do? You conduct sleep studies and administer therapeutic interventions, CPAP, BiPAP, and those type of things. You score studies for sleep staging and respiratory events, troubleshoot equipment, make sure the patient is taken care of, just like any good in-lab type of a situation, any caregiver. We educate patients on sleep disorders from the ground level, from the basic, from the front lines. And then we have to collaborate and help teach other physicians and other technologists as well. Typically, that's an associate degree or higher that actually takes care of that. So while you sleep, a technologist basically monitors brain waves and eye movements, heart rate, breathing patterns, blood oxygen level, SpO2, SaO2, body position, chest and belly movements, limb movements, and snoring and other noises that are going on, and also any, can be parasomnia type of activity, REM behavior disorder, those kind of weird activities that go on. But that's what a polysomnographic technologist does, as well as you have to learn how to connect electrodes and other ancillary equipment. And in these pictures here, you see down in the bottom left, the patient being actually hooked up by a sleep technologist. All the monitors in the upper left corner here, leg movements, breathing, breathing effort, breathing airflow, CPAP, microphone, and electrodes that are on the patient as well. And you have to learn a little bit about the instrumentation of what a polygraph does, which is a computerized sleep system. So when we're talking about sleep laboratory sleeping rooms, this is basically what one looks like in general. The in-lab sleep suite typically has a camera to view the patient with infrared illumination, nurse and intercall system, a bed, a bath, and network connections are the most important thing, is having a network to be able to send that patient data from the patient's room into a separate room that will have a technologist monitoring that. Now, there is equipment that is able to record without anybody there. Those are type 2 type of apparatus. They can be done in the home, they can be done in the laboratory, and then you can download them in the morning. These are differing opportunities for limited resource places that can have, and it's hard in a short bit of term to be able to explain what the positive and negative for in-lab versus home and all that kind of thing. But for an in-lab sleep suite, these are basic essential. Some can be left out, but that is there. A separate control room for night staff to view the studies if you choose to go with that model rather than a record and download later. And a polysomnographic or a PSG computer system that is able to record, and they're specially designed for those for these type of studies. to be able to amplify brain waves as well as respiratory monitoring, and other values that we look at in sleep studies nowadays with, carbon dioxide and those kind of things that are out there. So when I'm putting together the talk, and when I've talked to other institutions that we're partnering with setting up new laboratories and things, these are some thoughts that I have, and I don't claim to tout any one of them, but that's basically a resource of some of I have the 4 kind of ones that I know about. That's all I'm doing, and you can use this as a resource or whatever. There are some systems in this that do well in the home and record by themselves, use wireless technology. There are some that are hardwired for neurologic testing, for full brain activity and those kind of things. But basically all of these are global, they're available, and that's why I mentioned them here. And this is just a picture of what those kind of do. Part of any laboratory in 2025 is being able to do limited home sleep apnea testing equipment, and my thoughts on those, to be able to test in the home, but not having a full sleep laboratory, in-lab type activity that's going on the entire body. May include brain waves, may not include brain waves. It all depends on what your fancy, what you desire is. And just some thoughts on that. They're typically called type 3 monitors by the AASM criteria. Reduced monitoring, reduced setup, usually done in the home, but you can do them in a hospital room as well. There's significantly reduced raw data available, simplified and reduced to only the specific basis that could give you the diagnosis of obstructive sleep apnea, or other type of devices, depending upon how limited you wanted to get. There's a lot of different types out there. They're typically cloud-based, so you're not running equipment or software on your own devices. They're cloud-based. They have a lot of AI advanced analytics nowadays with a lot of these devices, disposable, non-disposable by the patient. These are all available in 2025, and it really, what fits your need in your startup or in your beginning, in your genesis of the monitoring sleep patients, really determines on what routes you want to go. And I've been able to do a lot of vetting of a lot of devices around the world, I guess, because most of these are not specifically located in the United States. There's just a couple of different devices that are out here. We do peripheral arterial tonometry, WatchPat, SomFit by Compumedics, Sleep Image, Z Machines, and Bleda. These are differing types of devices. These are more PAT devices. These are more cardiac devices. And these are more, in the lower right, the 2 Z Machine and then Bleda are more basically monitoring effort and airflow, respiratory effort and respiratory airflow, to detect between central and obstructive sleep apnea. So I showed you a bunch of them that are out there. There's also a ton more that are out there that you may desire more than that, but it's just some opportunities and to get your ideas flowing if you indeed want to start doing sleep services. So if there was any questions, I know our time is limited and I don't want to take up a lot of time. But if you have questions or for more information or any help, I've listed my email address here. You can certainly ask me any questions. We do have experience in helping people over the miles and virtually and those kind of things. It's kind of in our nature to do that here. But if you have any questions or anything like that, feel free to email me at any time. And with that, that's it.
I don't actually see any questions in the chat as of yet. Perhaps I can start off with a question. I noticed that children, for whatever reason, are not affected, it seems, as much as the adults with this trypanosomiasis and sleeping sickness. And I was curious about why that might be.
So I don't know if Prof.
I guess,
Lagarde is back, because that would really be more question for him.
yeah, I think so.
I'm not,
Okay.
I'm not, a specialist in that sense. I'm
Yes,
more
yes,
interested
of
in
course.
those mechanisms. So, but yeah, I mean, I could venture a few things, but they're probably wrong. So I will not, I, I mean, one of my guesses would be that, well, maybe, the immune system is still, very active and can probably, get rid of the trypanosomes at an earlier stage and prevent, the penetration, the CNS penetration, which is really when it becomes
Right.
a serious concern. That would be my guess, but very honestly, I'm not a specialist on that specific aspect, so I prefer not, saying for sure.
Okay, well, I have another question from a member of the audience. How do we check for some of these markers?
Again, that would be a great question for Prof. Bagatti. I think he had it in his slides. I mean, sorry, I'm not sure which markers we're talking about. I'm guessing it's markers for the disease itself, for
Yes.
trypanosomes.
Mhm.
So I mean, like there was the rapid test. I don't know, Prof. Komolafe, maybe you can also pitch in on that. But basically, I mean, there was the rapid test, but then you need confirmation tests, and there were quite a series of tests that were listed. But I think the first step is, well, I mean, you first have to think about the disease. I mean, especially if you're going to see it in a non-endemic area. Like for me in South Africa, there's very low likelihood that we'll see a case, except if it's a traveler brought, case. And I think it's people, so we were asking ourselves, about those when they actually detected in the CSF. So I think systematically, when people test positive in the blood, you will get a CSF, because you need to be able to say if it's more than 5 or less than 5 cells per, per milliliter. I can't remember what was the unit of the volume, but and so you have to first think about it, then you test, you do your rapid testing, you do maybe a more advanced testing. And then once you've done that advanced testing, you need to check whether yes or no, you already have a CSF, I mean, like a CNS infection, so central nervous system infection. And in that case, the treatment is slightly different according to whether you have just the hemolymphatic phase or the meningoencephalitic phase, which requires a little bit of a stronger treatment.
Okay, now I'm looking at the question again. It seems like it is specifically relating to interleukins. And
yeah, that's a very unspecific. So I'll, probably now with my big cold, which might be COVID, who knows? I probably have some high IL-1, IL-6 TNF because my macrophages have been activated. As far as I know, there's no specific cytokine that's yet been, detected as a biomarker. However, that's a very good question. There might be good biomarkers. Now with, LCMS, we might be able also to get even better biomarkers. But at this stage, I'm not aware of, something that's diagnostically helpful, let's say, in terms of cytokines. I'm for sure what Prof. Vadi, was mentioning in terms of the very specific tests. Then that's of course, very, you had for the PCR, you had like more than 95% sensitivity and 100% specificity. But of course, depending where you are, if you're in the middle of, in a very rural area, because as he said, the rural areas are more likely to have the trypanosome. Well, you're not going to find a PCR machine very easily at that point. Like in the middle, like in rural areas in Cameroon, there's not necessarily a PCR machine that's going to be available, or you have problems with access to electricity at that point, etc. So unless you have a dedicated center, because you know that in this place, there's a region where you have a high likelihood that you might detect it. But as Prof. Gabardi was mentioning, even we have been we've been doing a scoping review of sleep issues in sub-Saharan Africa. I mean, actually more in the South African development community, which is a little bit more to the south. And I mean, exactly what you were saying, that the prevalence is decreasing massively because, of the campaigns, the prevention, etc. So, again, I think having access to rapid testing is probably the best. And then as soon as it tests positive, you have to go, to a tertiary hospital and get the proper treatment there.
Okay. I think we have time for one more question. Are MSLTs used for people with this infection?
So, Prof. Gabarty is here. Yes. Okay, you can go ahead. Maybe you want to answer because I've been answering a lot of questions.
Sorry. Well done. Thank you very much for the discussions I've been following, although I've had issues with my internet. But I just want to chip in a little bit about pediatric heart. Children do get infections, but it's very rare. Maybe what one can think about is the exposure. Maybe the children are not as exposed as the adults because most of the infections are quite outdoors. So that might be a reason why children don't come down with the diseases as frequent as adults. Because there have been case reports of even congenital trypanosomiasis. This was discovered in an African woman in France some few years ago. I mean, she delivered, the child got sick, and then the child was born with infection with trypanosomiasis. So they do get infected, but not as common as adults do. Thank you.
Okay. So thank you, all of you, for joining this very, very informative session. And we will see you all at the next one.